Received of this training a couple of years back, and we found there's a couple of reasons for it, right? One of the things is during the pandemic, we can look at Khalil Center is serving is having wait lists across the country, right? Across our offices. We have about 300 patients essentially virtually lined up, right? Outside of our offices, if you can imagine, right? Waiting to get services. Now, you might imagine, I just want you to kind of think about this. You might consider, well, you know what? 300 people on a wait list, what is the conversion rate? Meaning, how many of them actually stay on and continue and will continue to wait for a Khalil Center? Because our wait list is out a couple of months that they have to wait. And what we realized, and I was asking our admin, the vast majority of them don't go anywhere else, and they actually wait to get in with a therapist here. And I'll show you other studies to show that 75% of our patients have not and would not have gone to any other mental health services outside of Khalil Center, many of which have never visited behavioral healthcare treatment, mainstream mental health care treatment outside of Khalil Center. So now, why am I saying this? Because there's an immense need, right, within our community. And I'm going to talk a little bit about this, but oftentimes people talk about, well, we have this huge stigma of mental health, right? That's true. We do have a huge stigma. But at the same time, I'm also realizing that Khalil Center is doing something in which we're melting some of those barriers, in which people are readily trying to access our services, right? So we have the floodgates. People are like, a lot of times we're talking about Muslims need to seek mental health care, and we should normalize it, and we should tell them to go places. Well, yeah, that's true. But the reality is many Muslims are already ready to seek mental health care. But what is it that allows them or gives them the confidence or melts some of the barriers for them to seek a mental health care? A very important one is when you do it spiritually integrated. That when you provide the service in-house from within the community, from within the tradition, we find that many people turn to Khalil Center. And some people might think, oh, well, you know what? Does Khalil Center only cater to very conservative, ultra-practicing Muslims, right? That's just like, because you're an Islamically integrated mental health care center, is that the case? And the reality is that's not the case. We have, people across the spectrum of spirituality, of spiritual practice, at least overtly, right? That we can, or in their, how much you're fasting and praying and that sort of thing. But we do find what is very interesting, is that when individuals face difficulty, psychological difficulty, they often turn to spirituality for solutions, right? And so Khalil Center is not the only place that people are going to, but the other place that people are going to is that where they're not going to behavioral health care, right? A lot of times, right? That's what we're finding, right? Where are they going to? Well, they're going to a lot of imams, right? Imams, I'm sure all of you, the imams, ai on this Zoom platform can attest to the fact that they, despite the fact that their training may not have prepared them for this, despite the fact that many clergy or individuals who study theologically may not have anticipated playing a role of a counselor. When they get into the job and the vocation, they realize very quickly that counseling becomes a very significant ask or part of the job, dealing with people's kind of human mental health, psychological or emotional challenges, in addition to obviously their spiritual care. But so much of their psychology starts to emerge that's wrapped up in a lot of the spiritual concerns or issues that they come in or seeking imams for. The other thing to consider is that, when people feel pain in general, emotional pain, they don't think of it in psychological jargon either, right? They don't think of it as in the sense of, depression. Oh, do I have clinical depression? Do I have clinical anxiety? Sometimes they do, right? Do I have a panic disorder? Oftentimes they're just like, I don't know what's going on with me, and there's something wrong. And they think of spirituality, right? And I'm going to get into this. Many people explain their suffering, many Muslims explain their psychological suffering through their faith, through their spirituality. So when we look at the first responder, there's a study that was found in 2005, and there's some updated studies that these folks have also done, that after 9/11, there's been an increase in seeking out imams. And of course, post-pandemic as well, there's an increase in seeking out help, right, for services to address a series of mental health related issues in the Muslim community. Meanwhile, few of these religious scholars had any formal training in mental health care. This was back in 2005. This is one of the motivations for our FRT program, First Responder Training Program. There's a lot of first aids out there, right? Psychological first aid, mental health first aid. But we thought there's nothing really tailored to speak to Muslim mental health issues specifically, nor is there any Islamic models of care incorporated into that. The inclusion of Islamic ideas and concepts that are embedded within that training. And so we conceived of creating our own. And we wanted to see this number change, right? This, less than 20%, right? Had any sort of exposure to mental health concepts or psychological training. And we wanted this to change. The realization or the reality is that people will continue to come to imams. And my suggestion is not that imams turn people away and just say, hey, I don't do counseling, send them all to mental health providers. Because the reality is we're also taxed, right? We have to have this integrated collaborative care approach. We do, of course, need to have a differentiation in our scopes of practice, right? In understanding that different people do different things, right? But there's also some space of overlap. And that is that there are some subclinical or non-clinical or very, very mildly clinical issues that may be very appropriate for an imam to be able to work with an individual, given that they have the capacity. And we're going to talk through scope and capacity and setting up your structure accordingly as well, in order to kind of give you some of that ability, but also to work with imams. A lot of times we've found, back then when we started conceiving of these programs, that I started finding many mental health practitioners being very antagonistic against imams, right? Feeling like imams are the problem, they don't know what they're doing, they're making people worse. I think there's kernels of truth to this, and I'm sure that Emma can attest to this, right? Certainly there's some bad pastoral care happening, right? Sometimes there's lack of training and mistakes. Sometimes there's youth and development, right? People are young and they're kind of learning the vocation and they're making practice. But to kind of categorically toss this category out, I felt is really unfair, given the fact that our community naturally will turn to imams. Our community respects and connects with imams, right? And also that we should work alongside and provide some resources and some education, training, and then also work alongside of imams and our religious communities in order to be able to adequately. Okay. So again, Muslim mental health, American Muslims oftentimes ascribe spiritual meaning and metaphysical causes to their distress, and they seek out traditional healers oftentimes before mainstream behavioral health care providers. Another interesting study in New York City is that the counselor, people were asked, Muslims in New York City were asked to what degree do you believe that your imam is a counselor or serves as a counselor, right? And the vast majority of them said that this was definitely true, okay? Now, the imams know, and I know, alhamdulillah, having the privilege of being able to study theologically in a seminary as well and continuing to do so, that we don't really, illa mashallah, unless there's some exceptions to the rule, in the regular Islamic studies curriculum, traditional curriculum, there is no kind of a counseling module or counseling training. Certainly, we study the fiqh of marriage, how to conduct a marriage, what are the conditions and things that lead to a divorce or might effectuate a pronouncement of divorce, right? And the types of divorce. What is a khula, what is a fasq nikah, and what is a sunnah al-talaq, what is a bid'ah talaq, these sorts, what is the ahsan al-talaq, right? These kinds of categories we go through, but we really don't do a lot by way of how to do marital therapy, right? And so there's a sort of a gap between what our community thinks imams do, right, or are equipped to do, versus what they actually have the training to do, right? And again, going back to this notion that certainly we want to set up this collaboration where we have this integration where people are doing what they're trained to do, but also preparing and giving our community the education as to where they can seek out what, right? And I don't believe that we should always, that sometimes there's an anxiety, and I call this kind of anxiety-based response rather than kind of what's proven to be effective. Sometimes we, as helping professionals, imams and therapists included, struggle with some of our own boundaries. And what we do is we start to feel like, what, this person's in a crisis, I have to help them, right? And I have to do something, okay? And then therefore we end up responding, and we have some case simulations. Somebody calls you, for a crisis, and you realize they keep calling you when they have a crisis, rather than potentially enabling that problem or opening yourself out for compassion fatigue or burnout. And I have many imam colleagues and friends, right, that'll just be like, I'm done doing counseling, right? They just sort of stop and close the door because it's compassion burnout. They're just like, I can't respond to people's phone calls all the time. I can't respond to people's emails all the time. Well, there's also a problem of being able to educate our community about, here's what I do and here's how I do it. Here's what I do not do. Okay? And here are things that I can do, but I work with such organizations or other folks around, right? And I think we put too much on the imam rather than being able to diffuse and share the load, to be able to have other people do different roles that we can sort of point to. And obviously there's a lot of complexities and challenges around this. There's, I'm very aware, acutely aware of funding that's available, board structures, culture, volunteerism, burnout, all these sorts of things that pervade our communities. But, the reality is we do carry, the imams, in fact, do carry the bulk, a huge burden of responsibility. By extension, youth counselors, by extension, halaqah leaders, by extension, our masjid community leaders. Why? Because the studies show that people tend to go first self-care, right? Then when they cannot, get their needs met through self-care, and they're struggling, they can't figure it out on their own, they go to informal community care, which includes your masjid now. Okay? So it's not a formal mental health care system that's set up for them. So what do? They go to the imam, they go to the halaqah leader, they go to their youth counselor, they go to whomever they have a solid relationship with. And so it's important for us here, right, to be able to triage them accordingly. If it's appropriate for you to deal with them, great, deal with them, because, you know, there's huge wait lists, there's costs, there's challenges associated with going through formal mental health care as well. But if you're finding that no, that's not the case, they need more care, then we want to escalate it. And if you go up this pyramid, you find that this is starting to change a little bit, but still, this is still the case. Many people seek mental health care services through their GPs, their physicians. They go to their doctor and they say, you know what? I really can't get out of bed. I'm feeling a lot of anxiety. I'm feeling a lot of stress. Or they have, psychosomatic type of symptoms. They have backaches. They have other sorts of headaches. They have bodily, a lot of fatigue, for example. And they're coming to their physician and they're saying, something's up with me. And they're not going to go to a mental health provider. They're going to go to their GP, and maybe they'll get some medication, or maybe they'll be triaged to mental health care providers. But as you go up the ladder, you start to see community mental health care services starts to be like a third or fourth option here, right? And so something needs to happen on a communal level to be able to address this and to be able to triage accordingly. And this is where Khalil Center is, right? Up in the orange. And then obviously there's a psychiatric general hospitals, but the community mental health services is up in the orange, right? And then you go, obviously, the more intense it gets, the more escalated it becomes beyond community care. But you can also see that the service costs are what? Higher. How much does it cost to talk to your imam? Usually nothing, though. Or if they've started to formalize these services, they've started to charge maybe something, and it's often more of a suggested donation than it is kind of a service cost. So it's not a fiduciary relationship is what we call it. Fiduciary relationship being one of a contract between a service that's being provided at a cost. And obviously, there's, what of the, just coming to the gaps. I'll come to the gaps. And what is Khalil Center? Obviously, at Khalil Center, we serve anybody regardless of their ability to pay. We do have a structure. Those who have insurance, we bill them. Those who don't, who can pay out of pocket, we, charge them out of pocket. We have a sliding scale, and then we have financial aid for them. So we do try to kind of reduce cost issues, because it is a huge barrier for mental health services, and also serves as a barrier for the imam to be like, all right, go to this provider, and the person's financially struggling and their stress increases because of the idea that they have to, pay $150, $200 a session to meet with a psychiatrist or psychologist, right? The importance of religion and mental health care. Again, 90% of Americans, right, turn to prayer and religion for psychological healing, for coping, psychological coping. Look at this study. 80% of a sample of mentally ill people used religious coping, right? So many people resort, and in medical treatment, a significant number of people report a desire for greater integration of religion and spiritual care. Many people with medical illnesses, forget about psychological, even turn to prayer and exercise and rituals and traditional healers before they even seek out primary health care services. So psychological care all the more so. Now looking at Muslim mental health care research, we find that 1 in 4 Americans, well, actually before getting to Muslims, this slide just kind of looks at people in general again. 1 in 4 Americans experiences a mental health or addiction problem at this time, okay? 25% of Americans have a diagnosable mental health condition. That's huge. 1 in 2 Americans will have a diagnosable mental illness in their lifetime, okay, before they reach the age of 40. So that's half the population. So the need is tremendous and immense. And every 2 minutes, somewhere in the US, someone is sexually assaulted. So trauma is also huge, okay, psychological trauma. And I know there's a lot now discussion around spiritual abuse. Other presenters may get into that a little bit, but we recognize that there is an immense growing need, and people having kind of either turning to religious clergy, right, for help, or turning to mental health professionals or other community leaders to be able to kind of heal or talk through some of their trauma. 1 in 6 males before the age of 18 and 1 in 4 females report some form of sexual abuse. So this is rampant, right? And they find that women of color are more likely to be victims of sexual abuse. There, just an aside, a study that comes, some other research that comes to mind is, the more closer knit or communal structures that are set up, more embedded the community is, the greater the risk of trauma as well, or sexual abuse, despite the fact that there is great advantages of closely knit communities. There's also risks associated with it, just to kind of keep that in mind. That's why, there has to be a lot more due diligence and protections and mechanisms set up and put in place for stuff like that. Looking at anxiety disorders show similar prevalence rates to the American national average among Muslims, which is at about 18%. Right? And mood disorders, depression is close to about 10%, right? PTSD is greater, trauma is greater in the Muslim community than it is in other communities, especially given that they're coming from, countries sometimes like refugees and whatnot that are coming from their countries of origin that may have faced trauma. American Muslims are also at greater risk in the sense that they're least likely to have someone they can count on if they're in trouble, demonstrating the disadvantaged nature of social supports for American Muslims. So the social support mechanisms we have in our community compared to other communities is fewer. Okay. Looking at American Muslims' marriage and divorce, American Muslims are doing better than the national average according to 2 studies on divorce rates, which is at 32%, and then 21% was actually a Bay Area sample of working professionals, so perhaps maybe not generalizable to the general American Muslim community, given that these people are more advantaged socioeconomically than others, and living in the Bay Area. So also, being able to afford to live in the Bay Area as a working professional is also another phenomenon. But there's also another study that finds, despite the fact that American Muslims may be less likely to divorce, 68% of American Muslim couples report having significantly negative interactions, and 56% of them report at least one moderate to major issue in their marriages. Okay, so we find that marriages, even though divorce rates may be lower, marriages are struggling in our communities, even if they're not necessarily getting divorces. Looking at suicide trends, this is from our own data of our patients, right? And we find that people who are coming to Khalil Center, if you look at this, reports of thoughts of death for females is higher, but if you combine both, we're looking at around 50% of patients are reporting suicidal thoughts. Okay. Now, keep in mind, just the presence of thoughts itself is not indicative of a risk. It's increased risk for suicide, of course, but this is the number that I think we want to look at, the plan. Okay. When we look at almost 20%, 15 to 20%, right, of our patients are reporting suicide, and I want to kind of contextualize this. and we serve close to 10,000 patients a year. 10,000 patients, all Muslim, by the way, 10,000 Muslim patients a year. 75% of them are not going to go anywhere else. If Khalil Center didn't exist, they wouldn't go for mental health services. 15% of that population on the lower end, around for the males, but if you average the two together, we're at about 20%, right? We can look at, of that 10,000 people, right, 2,000 people, right, are experiencing some serious degree of suicidal plan. Like they're making a plan to kill themselves, okay? And so this becomes, the stakes become really elevated here, right? Now, it's not to say that everybody completes, but the risk is getting really high up here. And that's also part of the reason why we had set up the crisis line, right? And sometimes we do some of the crisis sessions. So I'd like to believe that, alhamdulillah, our center has literally saved many people's lives, right? You know, just to kind of recognize the impact that you will have in your community as well, that this is something that we need to work collectively on in order to ensure that people don't come to a point where they want to kill themselves and commit and complete suicide. I don't think we want that on our hands in our communities. Looking at pandemic mental health effects, some of this stuff is new, so we're drawing upon some old research around quarantine, but a broad, body of research shows that social isolation and loneliness contributes to poor mental health. People who were sheltering in place around quarantine reported more worry related to coronavirus than those who are not. 54% of those who are suffering economically reported stress compared to 40%. So both are experiencing stress. Obviously, 54%, the 14% explanatory gap between the two is that those individuals who are economically impacted are going to feel greater degrees of distress. People who have pre-existing conditions are much more vulnerable. I'm seeing a lot more cases in our office. Very interesting, by the way, psychotic breaks, right? These are not chronic schizophrenic patients that are coming in to see us. These are individuals who are having stress-induced psychosis, okay? Meaning that they don't know what's going on, and they may be misdiagnosed as bipolar or becoming psychotic. That's not the case. They come in, they get stabilized, but then we realize that, we're always thinking or screening for, is this a kind of a prodromal phase or a kind of a sliding psychotic disorder where the person's going to sort of slip into a schizophrenia or a really poor prognosis? Is this the manifestations of a bipolar that has gone undetected? But in many of these cases, I'm finding they are truly stress-induced psychotic breaks, and then what happens, or a manic break, right? And then what happens is, or panic episodes, that then results in them becoming more stabilized and coming back to some degree of normalcy, but it indicates to us that, the current circumstances certainly make coping a lot more difficult for our community. Just to show you, in a study of those who underwent quarantine, 28.9% of them had symptoms of PTSD and 31% of them depression. The longer the quarantine, the higher occurrence of PTSD symptoms. 24 studies in collection documented the effects of quarantine, showing that participants developed symptoms of low mood, stress, anxiety, and depression. Now this is a really interesting study that I want us to kind of pay attention to come. This is very interesting, by the way. I want to show you this study. So we find, according to the COVID response tracking study conducted by the University of Chicago, only 14% of American adults are very happy compared to 2 years ago, okay? Compared to 31%, 2 years ago. Now, I want you to really pay attention to this 31% number, though, right? when we look at this 31% number, that is alarmingly low already, right? So what my my argument here is that we were already struggling, right, as a community and as a society before COVID hit. And I've been telling, when I've been doing some of these public talks, people are asking me, what are you seeing as trends with your patient population or at your center? What I'm seeing is a lot of stuff buried underneath the surface that are all coming out of the box now that COVID has hit, right? If you had family problems, you had marital problems, well, you could go to work. Both of you could kind of go to work, keep yourselves busy, keep busy with groceries and extended family tasks and whatnot, and you just kind of keep going, right? And you manage your issues. Now you're stuck in the house. There's a lot more interaction that's happening. And yes, there's going to be some normal distress that's associated with that. But those who have significant problems are going to come to the surface, right? If you had anxiety issues, this is going to heighten that. If you had OCD issues around contamination, this is going to drive it up because you've been told so far that don't worry about contamination, bacteria is okay, you can go out, don't be afraid of getting sick and whatnot. And now the entire society is telling you, stay home, you're going to get sick. Right? And then there's, should you, wipe down your groceries or not? And should you completely isolate and quarantine? There's obviously a lot of different, attitudes around this, around different people and personalities and families and whatnot and communities. But it is a case that if you had issues before, it's going to kind of come to the surface, right? And 1 in 3 Americans report coronavirus has had a serious impact on their mental well-being. Close to 60% say that it's affected their daily lives. And now we can contextualize and understand the huge surge in mental health care services being sought out from Khalil Center. Usually we've been able to kind of manage wait lists. Whenever we get a wait list, we try to knock it down, right? Within like a month or so, we try to kind of create more space, bring somebody on. But now we've onboarded, and I can speak for our Chicago office, like 4 different therapists, and we've been increasing the wait list since. It's not knocking it down, it's still growing. I mean, we may knock it down shortly, and then it just builds rapidly. So potential factors for the fact that people are not happy. And this is where theology or spirituality becomes really important, right? This is a part of spiritual integration. Well, this has been a growing problem. People have been reporting that developing a meaningful, what is a very essential or important in your life? What is the most essential things in your life? And we find that being financially well off has been growing from about 40% to, hovering around 75 to 80%, right? Those have been the growing materialism trends, right? And then we have, a reduction, right, in meaningful philosophy. In the 60s, over 80% of people felt that one of the most essential and most important things of their lives was to have a meaningful philosophy of life, right? Be it informed by their religion or spirituality or whatnot. And that's dropping. And we find that there is lower resiliency among those who have spiritual outlets or who have a spiritual framework, right? Religious affiliation in the United States is at its lowest point since it began to be tracked in the 1930s. Physical and psychological difficulties for adolescents, college students, and adults are present for those who hold materialistic values. The more materialism, the greater the psychological distress. I just want to caution, though, this isn't a necessary relationship. What I mean to say is that, somebody could be spiritually well off, but still psychologically ill, right? Because I'm not suggesting that, and I'm going to get into this in the second module, so how do we understand this relationship between spirituality and mental illness? There's definitely evidence to show that the greater spirituality, the lower psychological illness. In fact, integrating religion and spirituality into mental health care increases and makes more effective treatment, right? And increases coping. So certainly a relationship. But you can also have somebody who is very spiritual also have a psychological disorder, mental illness. And I'm going to leave that question hanging. I'm going to come back to it to answer how do we sort of understand that relationship. Muslim college students, we look at this study compiled by the FYI, we find some of these alarming things happening, right? In particular, look at the alcoholism, right? Alcohol consumption, tobacco consumption, males more than females, and perhaps some of this is going down. Gambling, marijuana usage, and perhaps this is now going up, right, given the loosening kind of restrictions and legalization, decriminalization process. Illicit drugs. When we look at premarital sex, this is sort of concerning for our community, right? This data is concerning for our community. What are the barriers for Muslims seeking mental health care services? So we have many Muslims do not seek mental health care from public or private sectors because of cultural and trust issues. Mistrust of service providers. Fear of treatment. Okay, what does treatment entail? I just want us to also just normalize anxiety around seeking treatment as well, for us to consider that yes, there may be a stigma, but you know what? Going to somebody, a stranger, and entrusting them with your very personal, confidential, sensitive thoughts for them to be able to influence, right, is, one should have a healthy degree of skepticism and caution, right? We shouldn't just be going to just about anybody. That's not my prescription, right? Just go to anybody. Certainly there's bad therapy out there. Certainly there's people in mainstream behavioral health settings, non-Muslims, that might be antagonistic or have stereotypes or discriminate Muslims. So there is some healthy degree of skepticism that prevents people from going. Fear of treatment, fear of racism, discrimination, sometimes simply language barriers, communication styles, and a really important one is culture and religion, right? That people want. Another barrier is finances, right? One of the main barriers, according to a SAMHSA study, is affordability, their ability to afford services. Another thing which is very interesting is that Muslims in general are more reluctant to seek mental health treatment relative to other groups. Perhaps that's changing with Khalil Center and people's willingness to come to places like Khalil Center, but Muslims have also been shown to avoid seeking psychotherapy services if therapists are not providing it within the religious and spiritual context. So this becomes really important. Muslims surveyed regarding preferred therapist characteristics was that they wanted a professional, okay? They didn't necessarily always want to go to an imam. They would go to an imam if they didn't have this available, okay? Because they're going to go to somebody who's spiritually oriented rather than secularly oriented. They wanted somebody who's a professional who has training, but also has religious understanding and can effectively integrate that into psychotherapy. Not just the Muslim, by the way, right? They didn't just want a Muslim. That does reduce a barrier. Just having a Muslim reduces a barrier in and of itself. But it doesn't kind of take away the other barrier, which is people want spirituality integrated. Look at our study, right? I mean, this is, and I told you about this, 75% of people, did you consider going to a non-Muslim therapist? 60% said no, 40% said they were willing to consider it, and almost 75% didn't actually go. You see what I'm saying? So people are not going. And what is the most salient feature? Our studies of our patient population shows that, the religion and spirituality becomes, in 97% of the cases, one of the most important factors for them to seek out a place like Khalil Center. At the roles between, say, clergy and mental health providers, we have overlap between them, but we also have a distinction. Just to set up kind of a model of collaboration between roles. This isn't unique to modernity. I wanted to kind of cite something that Imam al-Ghazali mentions in his Ihya, and he starts by quoting a tradition, a prophetic tradition, though weak. That's why I like to call it more of an Islamic tradition rather than prophetic tradition, because the sanad is weak. إذا قال صلى الله عليه وسلم إذا أراد الله بعبده خيرا بصره بعيوب نفسه ولهذا المعرفة طرق أعلاها أن يجلس بين يدي الشيخ من مشايخه. Right? That the Prophet, he's saying there's a prophetic tradition that says that if Allah wants good for a servant, then He will give him awareness of his own deficiencies. And so seeking awareness of your own shortcomings and introspection is an important thing. To having a awareness of my strengths and limitations and weaknesses is an important thing in our Islamic tradition. And he says, but to gain this awareness of yourself, there are many modalities, okay, of doing that. One of the most noble is to sit with a sheikh from the mashayikh, those who kind of specialize, usually in your zawiya, in your like your Sufi, more of your pastoral care provider, not just any imam, but somebody who knows how to deal with these issues. ويشتغل بما يأمره فعند ذلك ينكشف له تارة وتارة يكشف له شيخه. So you get involved with some of what they preoccupy you with, and in those instances, sometimes your own psychological or your weaknesses become apparent, or the person detects it in you and will point it out to you. Okay? And he says, so I just want to jump ahead. وطريق أخرى أن يطلب رفيقا صالحا عالما بأسرار هذا الأمر. And there's another modality, and this is what I wanted to point to. فيسحبه ويجعله رفيقا على نفسه ليلاحظ أحواله وينبهه على عيوبه فهكذا كان يفعل الأكابر من أئمة الدين. That he says this other modality is to seek out a pious, a knowledgeable person, somebody who's knowledgeable in the affairs of changing human behavior, of understanding human weakness and adjusting it, and to accompany that person and make them a companion over your nafs, so that you can be aware of your own conditions and so that they can make you perceptive and to draw your attention to your own deficiencies. So this becomes kind of the platform for us to consider that, having pastoral care, having chaplains, having psychologists becomes important in an integrative fashion and is not foreign to our deen. In fact, when we look at even the medical tradition, it becomes even more apparent even there. The hikmah tradition of having a hakim where you go and you disclose your matters too. And you can very clearly see that in Abu Zayd al-Balkhi. But there's also, the reason why I bring this out is because there's a differentiation in roles. There's somebody who serves as authority figure, and then there's somebody rafiqan salihan, aliman bi asrar hada al-amr. Then there's a companion who's not your religious authority, but is knowledgeable in these matters that can help you correct yourself. And so this becomes really important. So the differentiation between the roles, I like to say that the therapist is a process expert, meaning that they are an expert in psychological distress and its treatment. They can examine and assess based upon their understanding of relational patterns and psychopathology. They get extensive training in that. And they're not an authority. They typically work with an individual in a therapeutic capacity to be able to teach them the skills to be able to heal themselves, or to grow those skills so that they can become more resilient in the future, as opposed to an authoritative figure, a more authority figure. So I'm contrasting authority versus authoritative expert, right? So we may be authoritative in mental health and even spiritual integration, but we're not religious authorities in while some people at Khalil Center may be, but the vast majority would not be. They rely on behavioral science. They integrate religious concepts as suggestions, but not injunctions. And they're bound by their professional legal ethics, which is a clearly defined scope, which is, in fact, my argument to chaplains and imams is that your scope is not clearly defined as a vocation. And I think that's also one of the growth of our communities, that in many other communities, for example, in the Jewish community, in the Christian community, they have a lot more well-defined scopes of religious practitioners. The scholar, فَاسْأَلُوا أَهْلَ الذِّكْرِ إِن كُنْتُمْ لَا تَعْلَمُونَ. Ask the people of knowledge if you do not know. The people of dhikr, they can be a lot more directive. They have religious weight and authority. They can speak in educating and directing them about the tradition, and they might even be able to issue fatawa if they are trained to do so, right? Case-specific fatawa, of course. They're experts around issues related to fiqhi issues, and clinicians should defer to Muslim clergy for these consultations. And alhamdulillah, at Khalil Center, actually, we have a religious consultations department. So we have a theologian, and it's connected to the Darul Ifta at Darul Qasim, that addresses some of these issues. Let's say, for example, around marriage, right? Like you have this issue, did a talaq actually take place or not? What is the avenue, pathway towards seeking a khula, a fasq? These sorts of issues that come up. Is the person exempted from fasting? Are they not exempted from fasting? Or even theological issues. Some people might ask and feel guilt. What is my duty and responsibility to my parents and the rights, given the circumstances of my situation? And the therapist may not necessarily be in a position, nor should they, answer some of those more directive questions. Rather, the theologian may come in and to process that with them and to talk through some of the principles of deen to apply that to their particular situation. Lastly, clergy limitations. I want to caution us is that although spirituality works well, the greater degree of suffering and more severity of a psychiatric element or psychological element to this, the less traditional healing works, and in fact can be harmful at times for when utilized. Much experience may be gained by clergy, but interventions may not be informed by assessment of sort of the psychological condition and then being able to treat accordingly. And then the other thing is more logistical, right? It's just compassion fatigue. The imams have so much going on that to dealing with somebody's issue is not like one session treats all. This is like you got to work with them 6, 10, 15, 20 sessions sometimes. And in some cases, it's months, right? And so the question is, do you have the wherewithal and the capacity and the resources and time to be able to actually sit through and give the due right of what they actually need?